Welcome to this explainer. Look, if you're a busy OBGYN, you know exactly how evaluating amenorrhea can feel. Kind of like navigating a diagnostic maze, right? Well, today we're unpacking the 2024 ASRM Practice Committee opinion on evaluating amenorrhea. We are completely skipping the textbook fluff and focusing strictly on high-yield, actionable updates that you can actually deploy in your clinic. Okay, let's dive right into this. This is actually a pretty huge milestone for our field. It's literally the first time ASRM has updated these guidelines since 2008. Think about that. That's over 15 years of evolving clinical practice finally getting standardized. We're looking at a condition that affects 3 to 4% of non-pregnant reproductive age women, so having a streamlined, rock-solid, evidence-based approach is absolutely essential for your daily practice.
Diagnosing primary and secondary amenorrhea requires a streamlined approach targeting 6 main conditions using a specific toolkit, a pregnancy test, a pelvic ultrasound, and 4 core labs: TSH, Prolactin, FSH, and Estradiol. Adopting this specific workflow replaces historic trial and error testing with a direct path, getting patients to the correct diagnosis faster. The massive differential diagnosis for amenorrhea essentially boils down to 6 target conditions. These divide neatly into 2 categories: anatomical issues involving the outflow tract and hormonal causes, specifically PCOS, thyroid dysfunction, hyperprolactinemia, and hypogonadism. Once you have first ruled out pregnancy, TSH and Prolactin are mandatory first-line screening labs for all patients, regardless of whether they actually show symptoms. These 2 labs carry specific clinical nuances. Subclinical hypothyroidism requires treatment if the patient experiences menstrual irregularity. Prolactin if levels are only mildly elevated between 20 and 40 nanograms per milliliter, and the patient is asymptomatic, you must test for macroprolactin. Isolating the presence of biologically inactive macroprolactin confirms the diagnosis without subjecting the patient to an unnecessary and costly pituitary MRI. Primary amenorrhea requires evaluation if there are no menses by age 15 with normal development, or by age 13 without breast development. Here, the physical exam serves as the primary pivot point for the entire workup. This algorithm relies on breast development and cervical visualization. If a uterus is absent, periotyping distinguishes 46XX Mullerian agenesis from 46XY androgen insensitivity. If present without breasts, FSH testing separates high FSH gonadal failure from central nervous system defects or hypothalamic amenorrhea. By establishing the pelvic anatomy right away, the physical exam efficiently sorts patients into either genetic or hormonal testing tracks. Secondary amenorrhea is defined as the absence of menses for over 3 months in previously regular cycles or 6 months in irregular ones. Unlike primary cases, hormones drive this workup, as structural causes are rare without prior uterine instrumentation. The modern protocol dictates that once pregnancy, thyroid issues, and hyperprolactinemia are ruled out, you combine a transvaginal ultrasound with FSH and estradiol levels. This algorithm flowchart shows how these concurrent tests isolate specific diagnoses. A thin endometrium with high FSH points to primary ovarian insufficiency. A thin endometrium with normal hormones suggests uterine adhesions like Asherman syndrome, and normal or high antral follicle counts confirm PCOS. Using ultrasound to measure endometrial thickness alongside core hormone levels yields an accurate diagnosis rapidly, bypassing drawn-out historic methods.
And when you look at the actual data breakdown, it brilliantly highlights what you're really going to see day to day. Ovarian issues, mostly PCOS, make up roughly 40% of all secondary amenorrhea cases. Right on its heels is functional hypothalamic amenorrhea at 35%. Think about that. Between just PCOS and hypothalamic issues, you've already captured 3/4 of the patients walking through your door. So, I want to take a focused, deep dive into 2 incredibly critical, yet honestly sometimes misinterpreted core labs: TSH and Prolactin. These are mandatory screens, but knowing the nuances of handling abnormal results is going to save you so much time and save the system unnecessary costs. TSH is your mandatory, cheap first-line screen, simply because thyroid disorders chronically mess up ovulation. But here's the major takeaway for your practice. Even completely asymptomatic subclinical hypothyroidism needs to be treated if your goal is to get that patient back to regular cycles and restore fertility. And remember, always follow up an abnormal TSH with a repeat draw and a free T4 just to confirm. Which brings us to a classic clinical dilemma.
Hyperprolactinemia is incredibly common, right? But this is exactly where so many providers hit a wall in their workflow. When is it strictly necessary to order a pricey pituitary MRI, and when can you safely hold off?
Well, the ASRM guidelines give us a very clear answer. Before you even think about neuroimaging for a mildly elevated prolactin, ask your lab to pre-treat the serum with polyethylene glycol. Why? Because this incredibly simple step rules out macroprolactinemia. That's a biologically inactive, bulky form of prolactin that doesn't cause any symptoms at all, but it completely throws off your lab values. And get this, macroprolactinemia has a prevalence of nearly 20% in these patients. Ruling it out first is going to save you from ordering a massive amount of totally unnecessary MRI scans.
However, and this is a big however, if the true monomeric prolactin is persistently elevated, then an MRI is absolutely non-negotiable. And the reason is striking. The prevalence of a pituitary tumor in patients with true, persistently elevated prolactin sits remarkably high, right around 50 to 60%. And since the actual size of the tumor doesn't always correlate perfectly with the prolactin level, you just have to get that imaging done to be safe.
To close out this explainer, let's distill all these 2024 guidelines into actionable clinical pearls that you can literally start using in your practice on Monday morning. First up, here's a major practice shift you need to know about. The guidelines point out that while the old progestin withdrawal test historically played a huge role in checking for an estrogenized endometrium, it's really taking a backseat now. Doing an early transvaginal ultrasound to measure endometrial thickness, combined with targeted labs, is just way faster. It gives you a rapid, objective, and accurate diagnosis without forcing you or your patient to wait weeks for a withdrawal bleed.
The updated clinical formula is clear. Universally screen for HCG, TSH, and prolactin. Let anatomy guide your primary amenorrhea cases, and utilize a transvaginal ultrasound paired with FSH and estradiol for secondary cases. Adhering strictly to this algorithm avoids common diagnostic traps and unnecessary imaging, allowing you to get patients to targeted treatments without delay.
Thanks so much for joining me for this explainer, and I'll catch you in the next one.